Now we're going to have a couple of minutes from two patients who participated in a prospective randomized study, the first ever surgical mouth cancer study comparing two completely different treatments for the same condition. Come up. One, in both cases, the mouth cancer would be removed, but in the other, the glands in the neck would be removed. So half the patients would have the glands in the neck removed and half wouldn't have them removed. And so we've got two patients who had two different things who have experienced being part of a prospective randomized study. Raymond, do you want to talk first?
Yes, hello. For about 3 months I had a very painful tumour under the tongue, ulcer under the tongue. My dentist referred me to the Royal London for a biopsy and some tests. That resulted in a consultation with the professor who told me it was a malignant tumour, and he invited me to join his clinical trial, which was to try and collect data on the treatments and the outcomes in order to, in the future, by the collection of a number of suitable volume of statistics, to determine which treatments give the best outcomes. And I had a random choice made after I elected to join the trial, and the treatment came from that, and here I stand before you today. The choice was a good one, and the selection, the treatment was a good one.
How did you feel, though, about being told that you were going to be randomly allocated to one treatment or the other, and I wasn't making a decision and you weren't making a decision?
Well, I knew that if there were two choices, there was either a choice that was going to give me some kind of life, or there was a choice that possibly would end in a less successful, happy outcome. I felt it was important to me to contribute towards this study because I could see the value in the longer term of that collection of data across a suitable number of individuals to actually provide information for people in the future, for the doctors and the patients who are involved in this kind of thing, to know which actual treatments, which combination treatments give the best outcomes for men, women, age groups, whatever. They can take it from the statistics as to what works best, and the options of treatment can be far better focused to the condition.
Okay, thank you, Raymond. Maureen.
My name's Maureen Mercer, and after a routine checkup at my dentist in 2010, they noticed a white lesion under my tongue. It was microscopic. I didn't know it was there. It did not hurt. I went for a biopsy at London, and the results of that confirmed cancer. Being a heavy smoker from a long time, I just thought imminent death was looming. I was referred to Professor Hutchinson, invited to take part in his research trial. Randomisation and what it meant completely went over my head. Fortunately, my husband's a retired statistician, so he explained to me the pros and cons. Under the randomisation, I should have had the invasive surgery with a section down my neck, etc. Surgery for a couple of hours compared to 10 hours. I elected just to have the tumour removed. And as a result of that, my husband and I have both stopped smoking, and life's a lot better and a lot happier. That's it.
So during the year of Darcy Fellowship, I was luckily enough to be responsible for designing and implementing an enhanced recovery program for head and neck oncology patient over at UCH and subsequently at Barts Health. So what is enhanced recovery? It is a new way of managing elective patients, making sure that they are in the best state to go into surgery, receiving the best clinical care when they are in, preventing complication and iatrogenic complications such as nausea and vomiting, and also giving them the speediest recovery and return to normal function. It also gives you a program to recognize abnormal recovery early so that intervention can be implemented as soon as possible. This concept was actually pioneered by Professor Kellett in Denmark in the 1990s. So you might think, so what's the evidence behind enhanced recovery? There has been loads published for other surgical specialties such as obs and gynae, orthopedic, urology, and general surgery. There are plenty of randomized control trials in these specialties showing that the patient's care has been improved by the implementation of enhanced recovery programs. Not only they decrease the percentage of complication that patients experience, and and also reduce the length of stay during the same procedure. It has no expense on increased mortality nor readmission rate. And so this is a diagram. I'm sorry about being such a busy slide, but it's actually the schematic look of it that's most important. This is the patient journey from top left-hand corner, from the start of diagnosis to going through the surgical admission and being discharged at the end back to the community. All these blue boxes and little writings are a little bit of elements that we can actually implement to improve patient care. These include admitting them on the day of surgery so that they're not sitting in a bed the night before, giving them a carbohydrate loading before surgery so that they are not starved for so long and decreases the stress response to surgery, giving them better monitoring using the latest technology during surgery so that their fluid status will be better, and also early feeding, early mobilization, better pain control using new technology. So every little element actually makes a little bit of difference to the patient's recovery. Although we are not going to try and prove every single element is going to be significant, but we know that from other surgical experience, from the other specialty, that the whole program does work when you actually put it together, implementing it. But not only it has the benefit of that I've stated in the previous slide, it also involves the patient more so that they become an active participant in their own care, and that actually can improve patient experience of the whole thing. So why are we not already doing head and neck cancer enhanced recovery? It is because our surgery is major and complex. It involves many surgical and medical specialty and many different types of allied health care professions all working together. So coordinating everyone else in order to fix to a program has been very difficult. We wanted to improve patient outcome, not just by improving their surgery, but also by how we prepare the patient and help them through their recovery and journey. There's been no research done on this topic anywhere else at the moment. So through the help of the professors, Prof. McCall and Prof. Hutchinson, and the help of MFORS, I was lucky enough to be put into a position to conduct a Royal College of Surgeons funded systematic review on this topic. We are hoping that the result of this will form the foundation for funding bids for a multi-centre trial. There has been a recent national meeting on the enhanced recovery for head and neck cancer, and it has generated a lot of interest, and we have made contacts with the ARAS Society, which is based in Europe, who might want UK to lead on this, to develop a head and neck enhanced recovery protocol to be used hopefully worldwide. So these are some background information on enhanced recovery and how it works so far for other specialty, but I'm very excited that through MFORS and the research that we are doing, that we could develop something new for head and neck cancer patients. Thank you.
That was very speedy, excellent. Just a point about this. It consists of about 19 elements, and none of them have been tested against each other. And they will involve extra work by nurses, by all sorts of ancillary staff, and the problem is that's going to cost a lot of money. So what we really need to do is do research, rather than just implement the whole package, do research and see which ones are really relevant and worthwhile. Okay, so that's where we come in. So it's not enough just to say, well, it seems to make patients better, but which elements of it make patients better? That's what we need to do the research on.